Good morning, Millie.
Good morning.
How are you doing today?
Doing well. How are you?
I can't complain. I can't complain.
Well, that's all right then.
Little nippy over here this morning. I don't know if it was cold in Monterey, but it was in the mid 30s.
I don't think it's that cold here. It's about 40. It says 43 on my thermostat at home, so it's not as cold. No, hopefully we'll
Yeah.
have internet. Hopefully we'll have internet today. Our internet went out at White House yesterday afternoon. Comcast went down, and for the whole at least the whole few blocks of where Lighthouse is. So
Oh, did that involve the clinics or not?
yeah, well, not all the clinics, just ours, because it was just a Monterey issue.
Huh.
And it was still out when we closed last night. So we'll see what happens this morning.
That's interesting. I was out Monday, Tuesday, Wednesday, and I got here to set things up. And I'm doing this on my laptop because my in the office, the computer on Zoom, well, this computer doesn't pick up audio, and it wouldn't pick up video. I could hear, but it wasn't picking up my voice. So I don't know what the problem was.
Yeah. Well, I don't think anything went out. All the clinics didn't go out this week. The computers were slow sometimes. But anyway, it wasn't too bad. So
Yeah.
we'll find out today if the computers are on in a few minutes when I get to the office. So
Yeah. It is really tough when things aren't working. That's for sure.
Yeah, it is. So all right, scabies, good. What we need.
It's like the old days of going back to paper.
Paper was a lot of fun. It was a lot faster. You couldn't find anything in the chart, but it was a lot faster. So
that's true. That's true.
Yep.
Hey, Millie, can you see my screen there that says scabies? Can it be job related?
Yes.
Now let me advance one.
Yeah, that's good.
Do you see the second screen now? Epidemiology. Did the screen change?
Yes, it changed.
Okay, and now I'm back to the first one. You see the first one again?
Yes.
Okay, because last time I was having trouble advancing it for some reason. So anyway, good.
It looks good now.
Okay, thank you.
Mm-hmm.
Good morning to Leah. Good morning to Mickey. And Danny, and good morning all.
Good morning.
Good morning.
Good morning.
Hi, Katie.
Hi, Dr. Schumann.
We'll give it a couple of minutes and then we'll get started here.
Okay.
Okay, why don't we go ahead and get started, and I'm sure others will join us as we move along. What I wanted to talk today about is scabies. Can it be job related? Last time, you just recall, perhaps we talked about cholera and the job causation issue with a condition that was not very common when there was not a clear job causation, but ended up being a presumed job causation because the condition that arose was sufficiently uncommon in any other setting that we really ended up making the presumption that it was job related, even though we didn't have definitive proof that that was the case. With scabies, we're talking about an infestation where circumstances are similar. That is, it's not like an injury where somebody slips and falls, there's a laceration, there's some other obvious event that's the causative factor, but rather it's a presumption. But it's, in this case, in a situation where the frequency of scabies in the marketplace is much greater, and the presumption of an uncertain situation isn't quite as clear. With cholera, you recall, perhaps 2 weeks ago, we discussed that there were maybe a half dozen or so cases in the United States in the course of a year. In the case of scabies, it's much more common. And so in the United States, there are 1 million cases a year, and worldwide 300 cases. Let me ask, did my slide change? Can you see the second slide, epidemiology, with the picture? Anybody?
Yes.
Okay, all right. So I guess we're changing. All right then, thank you. So in any event, scabies is a much more common situation. I know that you all see it from time to time. I do. And it can arise in a variety of circumstances. And how do we determine in this situation if it's job related or not, what the cause was? Well, classic scabies, and we refer to classic meaning sort of the garden variety scabies that we see, in contrast to crusted scabies, which is a diffuse, much more serious condition, but it manifests as an intensely pruritic erythematous papular or pustular eruption, with the distribution as indicated in the diagrams. And so it occurs in the webs of the fingers and the wrists, the axillae, areolae, periumbilical area, waist, genitalia. And in adults, it rarely occurs above the chin. The head is generally spared. It's in young kids that we tend to see it. Scabies can be in other locations that are drawn on the diagram, but tends typically to start there. So this would be considered a typical distribution of scabies. Now, just from the standpoint of how it progresses, the rash itself is a hypersensitivity reaction, a type 4. And it's a reaction to the mite, which is the female scaboid entity, its eggs, as well as the little packets of feces. And you see in the diagram there, a female Sarcoptes organism, and depositing eggs in the course of its movement through the burrow. And the little black dots, which will show up on the next slide, represent little material packets of feces. And any of these can cause this hypersensitivity reaction. And the life cycle of the scabies is formation of eggs, and then a larvae, and then a nymph, and then an adult. And the females in the burrows deposit 2 or 3 eggs a day for about 2 months as they burrow along under the skin. And the life cycle of the mite itself is about 2 to 4 weeks. In classic scabies in the body, there are rarely more than 12 or 15 mites producing burrows, even though the rash tends to be much more distributed. The rashes tend to occur roughly in the area where the burrows are, but they can be distributed more widely than that. And so another picture of the mite, in this case, producing some of its packets of feces. Now, here's the important thing that from our standpoint, from a clinical perspective, the transmission of scabies usually occurs through direct and prolonged skin-to-skin contact. So the mite has to move from one person to another. It's not airborne. So there has to be some sort of direct movement, whether it's from one person to the next, or for fomites, as indicated there, clothing, bedclothes, other inanimate objects, non-organic objects. The movement has to be direct. And so the mite can live for 2 or 3 days off the human host in one of these fomites, but otherwise, typically it occurs with direct contact between people. And so it's most common among family members or sexual partners. and skin contact, casual skin contact, unlikely to result in transmission. So this has significance for us in determining what the cause of a scabies infestation is. As well, it's not transmitted from animals to humans. There are scabies mites that occur among animals, dogs, cats, and others, but they don't reproduce in humans. So we don't get scabies from our pets. And I've got some pictures of scaboid lesions that occur. In this case, the low back. You see here some pustular lesions as well as erythematous, slightly papular lesions. In the web spaces, erythematous, slightly papular lesions. The burrows that occur are very difficult to see, and rarely, I think, from a clinical standpoint, do we end up actually seeing these. Although in this case, this is a burrow that occurred on a forearm. Again, more papular lesions, generally in the distribution described earlier. Can occur on the palms of the hands, and so that's an unusual place in many cases for rashes, but can occur with scabies as well as a few other infections. And in some cases, it's more widely distributed, particularly as the condition goes untreated, can spread more widely beyond just the areas as mentioned in the typical distribution. And then there's a typical pattern, which I confess I've not seen in the past, but can occur on the external genitalia, particularly of males. And this is considered to be pathognomonic. Now, how do we diagnose this? What are the criteria for this? There are several categories that have been developed, and it's thought to be a confirmed diagnosis. If there's on light microscopy, one can actually see the mites, the eggs, or the feces. That's not something that we have access to, that sort of equipment. Whether those can be visualized on other high-powered device or dermoscopy. It's a handheld device that dermatologists and others have, and magnifies and allows one to see structures in the skin. It's typically the burrows. One isn't going to see really the mites or certainly the feces, but may well end up seeing the burrows. And if any of those three conditions exist, then one's certain that scabies is the cause of the rash. And then from a clinical standpoint, which is what our situation is most of the time, if we can see what are scaboid burrows visually, if we see the lesion affecting the male genitalia, that's considered pathognomonic. Or if there's a typical distribution and then the existence of both itch and a positive close contact history with a person that's known to have scabies, then that would be considered diagnostic. Frankly, in my experience, that rarely is the case. Most of the people I see don't have a known history of exposure to folks that have got scabies. And they do have, however, an itch and a rash that is suspicious, particularly if the rash occurs at night, or excuse me, if the itch is worse at night. I consider that to be useful information too. So when I'm making the diagnosis, most of the time there's a rash as described, either the pustular or erythematous papular rash in the pattern described, and then there's marked pruritus, especially at night. Now, making job causation decisions, and I've had several of these in the past year, arising both in hospital situations and nursing home situations, making a decision that someone who's got confirmed scabies, whether that occurred on the job or not. And we'll just briefly go over this as we've talked about before, but in any sort of job causation, it's an AOE-COE decision. It's arising out of and in the course of employment. And so there needs to be a causal relationship, some evidence that it can have happened on the job, and then there needs to be a temporal relationship. That is, the temporal relationship is reasonable. So with both of those, then we make a decision that something's job related. We make the decision then, job relationship, we have to first to determine if there's the presence or the absence of causation. Did something really happen on the job that reasonably caused the employee to develop a condition? Most of the time, it's fairly easy if there's a traumatic situation or something that is witnessed. But in other cases, such as scabies, that doesn't exist. And so we have to make the presumption. So we do make a diagnosis. And then we also need to determine if the person has, if the condition that has risen as the presumed job condition was the cause, the sole cause, or was it a partial cause? Now, in the case of scabies, obviously, we're typically talking about a sole cause. In other kinds of injuries or illnesses, there may have been a pre-existing problem. So we need to recognize whether what we believe is the cause of the industrial condition, illness or injury, there's been a sole cause or a partial cause. And then in the presence of some presumed causation, if there's more than one cause, what's the level of change in a person's condition? Has the level of the symptom, the complaints increased substantially? Is there a change, significant change in physical findings from pre-existing? Is there a need for increased medication, increased therapy, or some change in work restrictions? Any of those would signify a change in a material change in the employee's condition. And then we need to make our decision with a sufficient amount of certainty. And in the work comp situation, as discussed previously, we need to be at least 51% certain. In other words, on whatever criteria we're using, the condition, the cause, the presumed cause has made a material change in the patient's condition. We need to be 51% certain. In other words, more likely than not, we feel that it's the substantial, that we're substantially confident that there's a relationship and that the presumed cause has made a material change in the patient. And we use the terminology more likely than not, probable rather than possible, absent the occurrence of. These are all terms of art that in the work comp world indicate that we're sufficiently confident that the cause exists and that the condition we're discussing is job related based upon what the etiology is. Now, we'll go on to a case review, and this was one that appeared locally. It's been earlier or latter part of last year. And what I'd like to do is talk about this. It represents really a typical sort of situation where, in the case of scabies, trying to determine if it really occurred, scabies infestation occurred on the job or not. So the situation was a 47-year-old female worked at a local hospital or works at a local hospital as a housekeeper. She's been employed in that position for the past 17 years, cleaning rooms, changing linens, collecting linens, towels, and other items for laundry. She was doing typical housekeeping work in the hospital, in the patient's rooms. So she has no history of skin disease or dermatologic complaints. She's obese, BMI is 38, takes medication for hypertension as well as metformin for diabetes type 2. Now, there was a patient in the hospital admitted for a stroke who, in the course of being in the hospital, was determined to have scabies, coincidental to her admitting diagnosis of stroke. The employee mentioned cleaned the patient's room once daily for a week, immediately prior to the onset of a rash. The employee noted insidious onset of intensely pruritic rash on her lower abdomen and the axillae and on the groin on the 5th day of cleaning the patient's room and was determined to have scabies. So the employee was determined on some basis to have scabies. and the hospitalized patient was determined to have had scabies. And the question is, of course, then, was the hospital employee's scabies related to her work? Was it a job-related condition? So what else would we like to know beyond that sort of skimpy information provided? And we're going to pull up some polls here in a sec. But what else would we like to know about the condition, the patient, the employee's condition? What historical information is most valuable about the clinical information that we have, both the hospitalized patient and the employee? Did the the housekeeper's exposure to the hospitalized patient make a material contribution to her diagnosis of scabies? And what's your level of confidence? So let's pull up polls. And here's the first question. What else would you like to know about what other historical information would you like to know? The certainty, your choices and the multiple choices are okay. The certainty of diagnosis of the skin condition of the hospitalized patient, the certainty of diagnosis of the skin condition of the employee, the extent of contact by the employee with a hospitalized patient, or other. What other information would you like to know that wasn't already presented? Okay. So all choices were taken. What who felt the diagnosis? Maybe just comment on knowledge about the hospitalized patient or the employee's condition. Why would that be useful information? Any takers? Well, certainly in my experience, the diagnosis of considering the first two options, the diagnosis of scabies it's kind of a protean disease, and it's sometimes hard to know for sure. I mean, we make the diagnosis in the absence of seeing mites or burrows. We make the presumption that it's scabies, but there's not a test really that we can apply that will tell us that it's scabies. And so we're making the assumption that there was an accurate diagnosis of the hospitalized patient as well as of the hospital employee. So certainly knowing the extent of the certainty of diagnosis is helpful there. If it turns out that one of those really didn't have scabies, then the issue's moot. What about the extent of contact by the employee with the hospitalized patient? Anybody care to comment about that? What in our history suggested that this would be useful information? Anybody give me some help out there?
If they've had direct skin-to-skin contact for extended periods of time. So obviously if she's in the room or around the linen with the patient, but direct contact has to be made.
That's right, Millie. What we know though is that typically it takes some time for mites to move from one person to another. And although, we talk about when we recommend to patients as we're treating it for scabies that there be vacuuming, that there be some hygiene attention paid to the couches, the furniture in the home. It really is direct contact or in contact with fomites, bed linen, for example, or clothing, where it's worn by a person with scabies And then within a day or two, another person is in that bed or is sharing linen or sharing clothing. It's the incidental contact of being in the same room or handling linen that a patient with scabies has is an uncommon cause. The other issue there about extent of contact, there was another piece of information, which was that the housekeeper developed symptoms after 5 days of exposure to the linen of the patient. Does that, do we have any thoughts about that? And the symptoms then developed on the 5th day. So there was somewhere between 1 and 5 days of exposure. And if we think back to some of the information on the prior slide, one of the pieces of information was it typically takes about 2 weeks for the mite to be burrowing to cause symptoms, the rash to occur. So unless someone's had a pre-existing scabies infestation and has developed antibodies, the type 4 hypersensitivity reaction, unless antibodies exist from a prior infestation, prior exposure, it's going to take about 2 weeks for the symptoms to develop. So it would be unusual in 5 days of exposure, just and really minimal exposure for the employee to develop scabies from that. So the timing is a little troublesome as well. And somebody suggested whoever suggested other, what other information would you like to know about this? Who recommended other? There is other information potentially. What were you thinking of?
Dr. Schumann, maybe
Yes.
if one of her family members had symptoms, prior to her having symptoms, it would probably be less likely to be job related.
Yes, that's exactly right. That's exactly right. If this exists at home and sexual contacts and family contacts are typically what's happened. In fact, the recommendation for treatment, to me, for ivermectin or other, is generally treating the whole family because it's so common for it to spread. So that's exactly right. If there was some other source of exposure for the housekeeper, that would be really useful to know. So that piece of information would be very helpful. Okay, let's move on to the next one. So would you be interested in, and this was the information just brought out a moment ago, housekeeper's recent family history of scabies or other conditions. So knowing what's going on in the family, that would be very useful information. In fact, that would probably be your first question for the housekeeper. And then the other question is the housekeeper's dog or cat medical history. Any takers on that piece of information? Okay, so as we just mentioned, the family history of the housekeeper would be valuable. It's interesting to know if the housekeeper's dog or cat medical history, if what we would know about, if what we could learn about that, but probably primarily to reassure the housekeeper that if the dog or cat was found to have scabies, and I'm not quite sure how you would diagnose as it would be a veterinarian's diagnosis, but if that information were available, it would really be to assure the person, actually known or unknown, reassure the person that you can't get it from a dog or cat or other domestic animal. So just reassurance that there's not a relationship there. So would you be interested to know the timing of the onset of the housekeeper's rash and then the housekeeper's medical history, including prior skin diseases? Okay, so yes, both of those are of course pieces of information. Again, as mentioned, we would normally expect 1 to 2 weeks for symptoms to develop following exposure to the scabies, the scaboid mite. And also, again, knowing the medical history of prior skin diseases for 2 reasons. One is if the person has been exposed to scabies in the past, again, the individual may well develop symptoms much sooner than 2 weeks because there's antibodies to the mite and the eggs and the feces. So the symptoms will develop much more quickly. The other thing is that if the person has had rashes in the past that are similar, there may be a different diagnosis available. So you certainly want to know what the prior history, medical history of skin disease is. And so based upon this limited information, did the housekeeper's exposure to the hospitalized patient make a material contribution to her developing scabies? So this is one choice selection. And this is why the patient, one of the reasons the patient came to the clinic for determination as to an AOE-COE decision. What are we going to tell the carrier? What are we going to tell the employer about cause? And an interesting consideration excuse me, is in one of the patients I saw previously in the past year, there was exposure to, there was development of a rash that was considered to be possibly scabies. But apparently, I have no personal knowledge of this, but apparently when scabies develops, at least we were told in a nursing home situation, that has serious implications for that nursing home in terms of how that's going to be managed. And it may have been hyperbole, but what was said was that there was a possibility of having to close down the nursing home. That seemed a little unlikely to me, but nevertheless, it was a huge issue. So this ends up being, in some situations, a more important decision than just simply treating a condition. It has implications beyond that, sometimes in the workplace. So what are we going to tell the carrier? We need to have, as mentioned previously, in making a job-related decision, at least 51% confidence. That is to say, our conclusion we feel is more likely than not to be yes, job-related, or yes, be the cause. So possibly, and that would, I think, my sense is that that it's, well, I'll go on to the next slide here. So what I concluded and recommended to the employer and the carrier was that I thought it was probably not job related. Using the term possibly job related, that indicates, and that's a fair answer, we're saying essentially the same thing, that possibly in the work comp world, possibly means less than 51% likelihood. Probably is 51% or greater. So when we say something's probably job related, it's more likely than not the cause. When we say possibly, it's possibly the cause, but not the likely cause. So that's, I'm sorry.
Okay.
Okay. So I concluded that it was probably not job related, or similarly said, possibly job related, but not likely. So it's more likely than not that this is not a job related condition. And that was based upon two things, largely limited exposure, handling the linen. And in fact, most of the housekeepers are wearing gloves when they're working. So the exposure was really limited. And then there was a short interval of time between the exposure and the onset of the rash in the absence of a prior infestation. So my recommendation to the employer and the carrier was housekeepers got scabies, but unlikely that this is a job-related condition. Now, what can happen, as we've talked about before, is employees have the option of a QME, qualified medical evaluator. If they feel a decision we make is not accurate, it's not the decision they wanted, then they can go on to request a QME. So there's virtually nothing that we will do that's in granite that can't be changed by medical legal review. So it gives us, in some cases, more confidence about making a decision. And in this situation, my feeling was it was not likely a job-related condition. Now, could I explain where it came from? No. But the evidence suggests that it was not really a job-related situation. And with 1 million cases a year, it's a relatively common condition. So my recommendation was non-job related. Any questions about this or taking an approach like this to this sort of case or similar or other job-related AOE, COE conditions? Okay, let's just do this. Let's move on to one other work comp topic, which is first aid. And this is something that continues to arise in the clinics. Is something first aid, or is it a medical condition, or is medical treatment required? And there's some criteria we can apply to this. And it's particularly important to make this kind of decision. Most of the times when we make a decision, we can do it with relative confidence. But there's some situations where it's harder to know based upon the criteria. And there are some situations, in some of those situations, we have employers that are pushing for first aid, want conditions to be called first aid rather than a medical a reportable condition. So I just want to go over what the criteria are for that and share how we can deal with some of these situations that arise. Most of the time, employers who are asking for first aid don't push back that hard, so it doesn't end up being a real problem. But we get occasional employers where it really is a struggle from the standpoint that they want to continue, they want to call a condition first aid, want to manage this first aid. And so we'll just talk about how these decisions are made and how we should be handling these. So there are two sources of information about this. You see 30 CFR 50.20-3. CFR is a code of federal regulations. So there exists a compendium of all federal regulations on all topics, and some of those are medical. So the CFR, 30 CFR 50.20-3 says medical treatment, which means condition that's not first aid, includes, but is not limited to, the suturing of any wound, treatment of fractures, application of a cast or other professional means of immobilization, treatment of infection arising out of injury, treatment of bruise by the drainage of blood, excuse me, surgical removal of dead or damaged tissue, amputation, and permanent loss of a body part, or second treatment of second and third degree burns. So they're fairly specific in that, but there's more information. Also contained in the CCR is California Code of Regulations, which is California's compendium of all things related to the workplace, a portion of which applies to medical treatment. Says in section 1904.7, excuse me, basic treatment, you must consider an injury or illness to meet the general recording criteria, meaning it's a reportable injury, and therefore to be recordable if the results of any of the following occur: death, days away from work, restricted work, transfer to another job, medical treatment beyond first aid, or loss of consciousness. Now, this obviously doesn't cover all known situations, but there's some other criteria that we can use. So if any of these things happen, then it's considered an injury, not first aid. Now, in the absence of the above, first aid includes, so they describe for us also in the CCRs, what is considered first aid. Procedures which are diagnostic in nature and not considered by themselves to constitute medical treatment. So what's a common diagnostic procedure that might fall in this category? Well, X-ray, for example. So if the X-ray doesn't show a fracture or some sort of injury that's going to result in loss of time from work, reassignment to another position, medical treatment, etc., X-rays then are considered diagnostic and not in and of themselves medical treatment. So taking an X-ray doesn't make something medical treatment and not make it first aid. Visits to a physician or other licensed provider, physical exams, X-rays, hospitalization for observation. This gets into a gray area. We don't generally have to worry about that. Where no evidence of injury or illness is found and no medical treatment is given, do not in themselves constitute medical treatment. So if with lab testing, if there's lab testing to be done, X-rays, those are all diagnostic and not considered part of medical treatment. They don't make something medical treatment. First aid includes procedures which are preventive in nature and not considered by themselves to constitute medical treatment. So tetanus and flu shots are considered preventative. So administering tetanus does not make a condition for tetanus for a wound, does not make a condition medical treatment. It still can be considered first aid. Any one-time treatment and follow-up visit for purposes of observation of minor injuries such as cuts, scratches, first-degree burns and splinters, ointment salves, antiseptic dressings to minor injuries are considered first aid. So these also, this is out of the CCRs, these all would constitute first aid, not reportable medical treatment. Now, how many visits can occur? It says one-time treatment, but they do allow for a couple of follow-up visits. And generally, in my opinion, if it's beyond 2 or 3 visits follow-up, then it still can be first aid as long as you're not doing anything more than observation of a condition or watching for something more serious to develop. Now, how do we, so we make the decision, and then what do we do about that in terms of paperwork? So the CCR goes on to say that a physician or any provider who treats an injured employee, we nevertheless have to file a DFR, doctor's first report, for every work illness or injury, even first aid cases where there's no lost time from work. So if we call it first aid, we still have to fill out a DFR and send that in. And what happens is that will go to the carrier, but one of the boxes that we indicate that something's first aid, it's not going to open a claim for the employer. So we do have to send in a DFR though with for a condition that we're going to be managing as first aid. Now, interestingly, although the labor code, as indicated here, contains first aid exceptions for employers' reports, you know that employers have to send in an employer's first report that parallels the doctor's first report for any injury that requires medical treatment. But in the case of first aid, the employer does not have to send in their 50/20, their employer's first report. But we still send in the DFR. And then what happens is the insurance carrier is indicated here, or the employer, if the employer is self-insured, forwards the DFR to the Department of Industrial Relations, the Division of Labor Statistics and Research. So they keep track of these first aid cases, but they don't open an active claim. So for first aid, there's no exception from our standpoint. We still have to send in the DFR, but the employer doesn't have to send in the employer's first report. Now, putting this in some perspective, why is it that some employers get anxious or are so anxious to have conditions considered first aid, even in some cases where it seems like it's not even reasonably considered first aid? Well, from the standpoint of financial management of work comp expenses, employers have three options. Every employer is required, if you have an employee, even one, there's got to be work comp insurance. Now, the owner of the company is not required, particularly if it's a working person, not required to be covered under work comp. But any employees other than owners the company is required to provide work comp insurance. And typically, depending upon the size and financial resources, the company may be one of three forms, but the rules all apply in each case. In most cases, employers will take out a work comp insurance policy and they pay premiums on a regular basis, maybe quarterly, maybe annually, maybe monthly, but there's work comp insurance, and these are from work comp insurance companies. There's a second category where employers who can afford to do this are self-insured, but they outsource administration. So in other words, they're providing the money that pays for what's covered under work comp, but the administration of that, those benefits are managed by an administrative company. So it's the employer's first dollar. They may end up having some excess liability coverage up to a certain dollar amount for a claim, but the employer is financing this, but there's an outside administrative group. The third category is if some are large enough, they may be self-insured and self-administered, which is permitted. So they are paying all the costs unless they happen to have excess liability, and they're administering the benefits themselves. But in all employers are required to fall into one of these three groups. Now, what determines, in the case of work comp policy, that first category, and this is where the employers that I've been talking about get concerned, what determines the cost of their insurance premium? And for employers, particularly in California and other states where there's a large number of work comp claims and a large number of those are litigated, work comp insurance can be very expensive for various categories of employers. So what determines the policy, the premium amount that you pay? Well, it's the employee mix. All job categories have a numerical designation. And so when a company takes out work comp insurance, they have to indicate what categories of employees they have and how many in each of those categories there are. There's a determination of what the industry type they're working in, and then what's called an experience modification. And for a new employer who's not had work comp insurance before, it's those three categories, the first three: employee mix, the total number, and industry type, that determine whatever the premium is going to be. And then after the first year, it will vary. It'll vary up or down or stay the same. And that's dependent upon what's called the experience modification. And that's a 3-year running record of all medical and indemnity costs. And medical or medical treatment, and the indemnity costs are death benefits, disability, and rehabilitation. And so if an employer, a company, excuse me, has a record of costs, medical and indemnity costs, that are greater than what's the norm for that industry in which they exist, industry type, their experience modification is going to be greater than 1. It'll be whatever, it'll be higher. If on the other hand, they have a better record of less medical and indemnity costs, then their insurance premium goes down. And so whatever they pay is going to be a function after the first year of whatever their 3-year record has been. So one can imagine then if there's the extent to which injuries can be managed under first aid, which are reportable, but no open claim is caught, no claim is opened by the carrier, then those expenses are not recorded and don't affect the experience modification. So it's to the benefit of employers to keep their costs down, medical and indemnity costs, in the interest of reducing their experience modification. So we have some number of employers that are really anxious to manage as much as possible under first aid rather than work a reportable injury. Now, what happens in the clinic when a patient comes into DOD, recognizing what we've just presented here? And there's sometimes, and I'm sure you've all seen it, employers will want to specify in advance, they want a claim managed as first aid. They don't want it as a reportable injury. Well, that's a decision we make. That's not a decision that the employer makes. So what we need to be doing is letting them know at the outset that it really is a medical decision as to whether a claim is going to be handled as first aid or not. And so what we need to be doing is following the criteria. And again, at the most basic level, if we can send an employee back to work to do their regular job, there are no restrictions or limitations. They're doing their regular work. The employer is not going to put them in a lesser job with a nod and a wink and manage whatever their condition is. If there's no lost time and if there's no prescription medication, then something can be handled as first aid. If, however, one or more of those criteria are exceeded, the employer is going to put them in lighter work because of the condition. We're going to assign restrictions. We're going to take them off work. We're going to give them prescription medication. Then something cannot be considered first aid. It needs to be considered medical treatment and designated as such on the DFR that we're going to send in, because again, we're going to send it in whether it's first aid or medical treatment. Most employers will understand that. And sometimes I'll end up talking to an employer about this and how we make the decision, and just indicate that it's not something that we can do as first aid if it's not really, according to the regulations, to be considered first aid. So most of the time it doesn't prove to be a problem, but there are some situations where it can be. Now, one thing we can do is if it's really one of those borderline cases and you're not quite sure, and I'll ask Scott or Katie or others to comment if there's some different thoughts about this, but to do something as first aid, but then on a follow-up visit or the second follow-up visit, it's clearly becoming more of a problem. The patient now needs to have antibiotics, or there needs to be physical therapy or some sort of restriction in their work assignment. Then we can notify the carrier that we're going to consider this now medical treatment instead of first aid. And we've already sent in the first report, but we're going to consider it medical treatment at this point. That doesn't happen really often. And the only time that I would do that is take that approach from the outset is with an employer with whom I have confidence, but that is an option. So that's how I handle it. But if I'm not pretty sure, pretty comfortable with the likelihood that it's first aid, then I don't do that. So I don't know if is Scott with us or Katie. I don't know if you have any different opinion about that than what I'm suggesting.
Steve, in my experience, I mean, if it appears after the second or sometimes third visit that it's not first aid, we could just go back and convert the first visit to a DFR and inform the insurance company. And as far as I know, they are okay with that, and it just moves forward. I mean, the employer's usually disappointed, but the insurance company just does it.
Right. Yeah. So this would be an unusual situation. We really ought to be making the decision at the outset, and it's going to be the decisional stand. But sometimes there's some of the gray area. So, you can consider that as an option. Now, there are some situations where it goes a little bit beyond just the employer wanting to have the condition managed as first aid. Sometimes we have employers who don't have work comp insurance. That's not real common, but that can happen. So that's a challenge. Let me mention these other two things, and then we can decide or talk about how to handle these. Sometimes, which is a little bit more common, employer refuses to provide us, if we haven't seen them before, refuses to provide us their work comp policy information and just says not going to give it to us. And then the third is, in some cases, we know who the carrier is because we've seen patients before, but the employer refuses to send in the employer's first report. Carriers aren't able to open a claim if they don't get an employer's first report as well as the provider's first report, the doctor's first report. So that can be a sticky thing. My feeling, and again, I'll ask Scott or Katie or others to any of you to comment about, but if an employee comes in and identifies they've got an industrial, something happened on the job, what we're generally doing is sending them back to their employer and saying, you need to report this because we're not able to manage it on a non-industrial basis. As it happens, it's a misdemeanor that we're committing if we knowingly treat a condition as we don't report it, treat it as first aid when it really is a reportable condition. I don't know how often that's enforced, but we do have some exposure there. So if somebody comes in and tells us that something happened on the job, but they didn't report it, or they reported it, nothing's happened, they need to go back to their employer. It needs to be managed as medical treatment. I would say this, my own feeling is, but I would solicit comments. If there's an employee that comes in that's got an obviously serious problem and needs treatment, if it's something we can manage, they're bleeding or they've got what seems to be maybe a fracture or something serious, I think we're really honor bound to provide at least initial care and then worry about later how this thing's going to get handled. Or if it needs to go to the ER, we send them to the ER rather than back, obviously, to their employer. But in most cases, that's not what we're seeing. It's not what presents itself in front of us. And so we really need to send them back to the employer. And then see what's going to happen. I don't know, Scott, do you have any additional thoughts about that, or Katie?
No, Steve, I mean, that's typically how it happens. The patient comes in, especially if it's an emergency situation. We just take care of the patient. I mean, there's probably, there's a small percentage of those, honestly, we may not get paid for, but, we're not going to, refuse to see a patient with a bleeding finger because we might not get paid. We're going to do it and then go back and get all the information later.
Right. So what you need to do is make your best judgment and stick with it. Just determine what you think the right thing to do is based upon the criteria we've mentioned, and then determine if it really qualifies. The decision should be, does it qualify as first aid? And if not, then it's medical treatment. It's not, is it medical treatment and then everything else is first aid? Our default is that something's medical treatment unless it qualifies as first aid. So most of the time this will work out okay. there have been situations, there was at least one in Salinas around the time I came 14 years ago, where one of the provider groups in town had developed some sort of relationship with a manufacturing company where they were considering everything first aid. And that ended up resulting in litigation and a serious problem, because the issue there is insurance fraud on the part of the employer to defraud the work comp carrier, because the carrier is providing cost of coverage based upon the criteria mentioned, I mean, how many employees, but also particularly experience modification. And if the experience modification is artificially low, then the insurance company, the premium charged is going to be less than it ought to be. So there's an insurance fraud issue for the employer, and if this were something that was being done on a regular basis by a provider or provider group, then there's some culpability as well there. And so I think in our group, this problem doesn't rise to that level. We're making our best decisions, making our best judgments about whether something's first aid or not, and just taking each claim individually.
Steve, one of the I guess complaints we get from employers is, I've seen a couple times, which is really an easy fix, is the patient that is put back to full duty needs maybe no follow-up, but and it's everything about the case is looking like first aid, but then the provider writes the patient for 600 milligram ibuprofen for pain instead of asking that patient to take 3 over-the-counter Advil for pain,
Right.
if they need it. So it was 90% there. Everybody was about to be incredibly happy about this, and then there was a prescription.
Right. And the best thing to be doing is folks can get 200 milligram ibuprofen over the counter. And what I usually tell them in a situation like that is, and if they're taking over the counter medication, aspirin, Tylenol, excuse me, non-prescription medication, then I just encourage them to pick up that medicine on their own and take it as labeled at non-prescription strength, 200 milligrams, 3 or 4 times a day.
Dr. Schumann, you've got a question in the chat from Dr. Maris.
Okay, I can't see chat, unfortunately, on my.
He asked if the patient's private insurance can sue the employer for payment.
Yes, actually, what can happen is and where this tends to arise a little more often is in things like motor vehicle accidents, where there's a significant cost of care. And I think the term of art is subrogation. In any event, it's something where the non-industrial insurance company negotiates, or on some basis arrives at a solution with the work comp carrier. Down the road, it's determined that it was really a job-related problem. That's a situation where early on the insurance company doesn't know that the workplace was necessarily involved. On the other hand, if it is a situation where the employee goes to the family doctor, goes somewhere, indicates there's a job-related problem, and it's a family doctor who's not familiar with work comp, and there's an attempt to manage the care under group health insurance, then if the insurance company, as I understand, the group health insurance discovers early on or at some point, then they'll refuse to provide care. So, but there can be a working out of this between the group health insurance and the work comp carrier at a later date, if that's something that's appropriate. But again, if we know something's job related, we really just need to manage it under work comp. I would never send a bill to a carrier or a claim to a carrier for something that we know is job related. That is to say, group health insurance carrier. Does that answer the question, or was there a specific circumstance that someone was wondering about? Okay. Well, that's the story on first aid. If you have any questions, give me a call, send me an email or something. Happy to talk about it. And if you have any questions down the road about scabies or something similar, then always happy to chat about those. And as mentioned, Scott indicated starting next month, his regular get together will be on the second Thursday, and then we will have and that's from 7 to 8, and then we will have the work comp discussion on the fourth Thursday, only one meeting a month, and that'll be every month, fourth Thursday from 7 to 8 as it was today. All righty, thanks for your attention. Appreciate your coming.
Thank you, Dr. Schumann.
Thanks.
Yeah, thanks, Steve.